Hello everyone, my name is Ahmed Hassan. I am an emergency medicine senior registrar. I have 4 years of UK experience and a total of 13 years working in emergency department. This is my second time running an FRCEM SBA course. The first course achieved excellent result with more than a 70% success rate among participants. I am excited to work with you all and help you prepare effectively for your upcoming exam. Today's session will follow a simple and structured agenda. First, we will begin with a brief introduction so you will know and expect what we're going to do in this course. Next, we will go through the FRCEM SBA curriculum in detail, highlighting the key domains, the weighing of each section, and the area that commonly challenge candidates. After that, we will discuss the best sources of study. I will guide you through the most reliable textbooks, online resources, question banks, and guidelines that will support your preparation. We will then move on to practical tips and advice based on my own experience and the feedback from previous successful candidates. This will include strategies for studying, managing time, and approaching SBA questions effectively. Finally, we will look at example questions to help you understand the exam format and the process you require to pass this exam. We will break down how to analyze options, eliminate distractors, and choose the most accurate answer. By the end of this agenda, you should have a clear understanding of what the exam demands and how this course will support your success. In the introduction section, I would like to give you a clear overview of the FRCEM SBA exam structure and what you can expect from this course. The exam consists of 180 single best answer, divided into 2 papers. Each paper contains 90 questions and is completed over 120 minutes. The exam is designed to assess wherever you have the knowledge, judgment, and decision-making skills expected of an emergency department consultant. As you know, this is a very tough and demanding exam. Many of our candidates find that it's a real challenging, and this challenge lies not in understanding the question, but to find a suitable answer and to navigate through these answers. So we will try to follow a structured approach to find the correct answer from the option given in the exam. Our course is built to give you a step-by-step through a systemic study plan, and we focus on understanding the curriculum, recognizing the pattern in SBA questions, and developing a consistent method for analyzing and answering choices. In our course, we will be exposed to a wide range of high-quality questions sourced from multiple references, including RCEM, NICE guidelines, and lots of other options. By the end of our course, you should feel more confident, more organized, and much better prepared to face the FRCEM SBA exam. On this slide, we are looking at a structured breakdown of specialty learning outcomes required in emergency medicine, along with the associated curriculum domains and indicative questions in the exam. As you see, SLA1 is talking about care for physiologically stable patient in ED. This section listed a wide range of clinical domains including allergy, cardiology, dermatology, ENT, elderly case, and etc. This represents the knowledge base needed to manage a stable patient across full spectrum of emergency presentation. This SLO is represented in the exam by 35 questions. SLO3 is talking about resuscitate and stabilize patients and focuses on resuscitation specific skills including recognizing critically unwell patient, initiating life-saving intervention, and understanding when to escalate or discontinue resuscitative efforts. And also, this SLO is represented in the exam by 35 questions. SLA4 is talking about care for injured patients. This area emphasized management of trauma and painful condition including evaluation, analgesia, procedural sedation, and stabilization, and also represented by 35 questions. SLO5 is a bit different, which is talking about emergency care for children across all stages of development. This is an extensive section covering dermatology, ENT, gastroenterology, infectious disease, neonatal emergency, MSK issues, safeguarding, socioeconomic crisis, and surgical emergency in pediatric. Also presented by 30 questions. SLO6 is specific in delivering key procedure skills, which includes POCUS, chest drain, airway management, pediatric sedation, percardiocentesis, NIV, sclerotomy, lumbar puncture, and others. It is represented in the exam by 20 questions. The rest of SLOs are being represented by less number of questions in the exam. However, they are very important. So we got here SLO7, which is how to manage complex or challenging situation in the ED field. It covers medical legal issues, organ and tissue donation, safeguarding, ethics, and critical importance for safe and effective leadership in the difficult ED scenarios. SLO8 is talking about leading the ED shift, which is focuses on operation leadership like patient flow, risk management, clinical governance, and to ensure the department runs safely during high pressure. SLO10 is participating in research and manage data. This is including research methodology, systemic reviews, basic statistics, ensuring clinicians understand evidence generating and interpretation of research. The total number of questions in the exam, as we see, is 180 questions. So the first 5 SLOs are the main part of the exam. So if you focus on the first 5 SLOs and also give yourself a time to study the last 4 SLOs, that will guide you towards the success of this exam. On this slide, I'm highlighting the essential study resources that support learning across the emergency medicine curriculum. These resources are widely used by trainees and consultants alike. They are alike closely with SLOs we reviewed earlier. The first source is RCEM Learning website. This is one of the primary online platforms for emergency medicine education. RCEM Learning provides an extensive library for e-learning modules, CPD activities, podcasts, cases, and self-assessment questions. Some people and candidates say that if you depend on RCEM Learning, you can success and pass the exam, as inside this website it can navigate you through other different websites and resources including GMC, NICE guidelines, ALS, ATLS, and other websites that are recommended by the examiner for RCEM. The second website is RCEM Clinical Guideline. These guidelines outline best practice standards across a huge range of emergency presentation, from sepsis to head injury to safeguarding. They are frequently updated and should be your first point of reference for ED protocol and managing pathways. The third one here is the ALS, APLS, ATLS manuals. These internationally recognized life support manuals provide structured algorithm-based approaches for critically ill or injured patients. Then we will see here the NICE guidelines, which provides evidence-based national guidelines across all medical specialties. They are very helpful and they contain broader clinical decision making, ensuring that ED practice stays aligned with national standard for diagnosis, investigation, and treatment. Then we have here GMC, Good Medical Practice website, which cover SLO 8 and SLO 10, the leading and challenging situation in the ED. As we see, this resource outlines the professional, ethical, and behavioral standard expected of all clinicians in the UK. Then some clinical websites, including Life in the Fast Lane, and the very important part of the Life in the Fast Lane, which is ECG Killer. You will find part 1 and part 2 in ECG Killers. At least you will find 2 or 3 questions in the exam from this website. The Life in the Fast Lane is not only containing ECG killers, but you will find a variety of other questions including ultrasound, ECG, clinical scenarios, psychological scenarios, mental health patients. So this is a very, very important and very useful website. And here we have a Don't Forget the Bubble. It is specialized in pediatric questions. So if you want to see more specialized questions in the pediatric, go for Don't Forget the Bubble, which is also recommended by the RCEM examiner. Now, let's take a closer look at how our course is structured and what learner can expect throughout the program. The entire course has been organized into 5 comprehensive study groups, each designed to mirror the emergency medicine curriculum and deliver high-yield learning in a structured and progressive way. Each study group focuses on a different components of the curriculum, allowing the learner to build their knowledge step by step. The content is organized to support post-clinical understanding and exam preparing, ensuring that nothing essential is missed. One of the strengths of this course is an extensive question bank. Our candidate will have an access to over 3,000 high-quality exam-style questions, carefully mapped to the curriculum and designed to reflect the style, complexity, and distribution of real assessment questions. Then we will move to the course pictures. We have extensive clinical image libraries, including ECGs, from basic pattern to high-risk cannot miss diagnosis. Then we have X-rays, including trauma, chest, abdomen, and pediatric cases. We have echography clips supporting acute cardiac assessment. We have ultrasound images and videos aligned with core ED POCUS competency. Then we will move towards our specialized part of our course, which is SLO-based mock test, which support the structured curriculum revision. We have multiple SLO-based mock tests. Each mock focus on a specific specialty learning outcome, like resuscitation, trauma, pediatric, procedure skills, and imaging. At the end, we will have a full-length final mock exam. This is designed to replicate the timing, difficulty, and structure of the actual exam, giving you a realistic test environment and a final snapshot, and to make you ready for the real exam. So now let's talk about structured study plan designed to guide your preparation from foundation learning all the way to the final revision. So I highly recommend following this plan because I found it more suitable for preparation for the exam. We will start with FRCEM SBA General Group. This general group contains full set of guidelines, all ATLS, APLS, and other guidelines. Also includes ECGs, X-rays, ultrasound, pictures, and videos. Once you finish all of that, go to the SBA guidelines collection. In this group, you will find the guidelines you studied earlier, and you can test yourself and see how can you expect a question related to this guidelines in the exam. So you will see the guidelines, then that will be followed by from 5 to 10 questions that you might expect seeing in the exam. Then after that, I highly recommend to go through FRCEM SBA collection of questions group. This group contains lots of new questions. Those questions are being collected from different websites. As I mentioned before, I have created all of these new questions to get you ready for the new questions in the exam. Each SBA exam, you will find about 30 to 40 very new questions. And I expect if you will see any new question that will come from this group. Then we have RCEM Learning Group website. This is a collection of the RCEM Learning modules in the RCEM Learning website with answers. So if you don't have access to the RCEM Learning website, you will have the questions coming from the RCEM Learning modules there with the answers as well. So it can save you time from scrolling and go through the different learning modules. And also they are very, very important. As I said before, some candidates only depend on the RCEM Learning website and they pass the exam. The last one is a last revision group, which is exam style questions focusing on the most important topics in the curriculum that repeatedly present in the SBA exam. So I recommend to keep that group till the end and do it more than one time so you can cover the most important and most recurring questions in the exam as well. So don't do it only once, do it 2 or 3 times before the exam. So now I'm gonna share some questions. The scenario page similar to the exam questions. They are not in the exams. but they can give you an idea how the examiner think when they choose the questions in the exam. So the first one here, uh, with regards to spontaneous pneumothorax, which of the following is an indication for cardiothoracic referral? So in the exam, you will find 2 or 3 answers will be like nearly correct, and 2 of them will be uh, definitely not the right answer. So whether you know the correct answer or you discard the wrong answer, so you will get 2 or 3 answers. You're gonna think about the right answer from them. So the patient over 50 is not a right answer. Recurrence ipsilateral pneumothorax, yes, might be. Failure of lung expansion 48 hours chest drain after chest drain insertion, might be. Any secondary pneumothorax, no. First presentation was planned scuba diving trip, no. He is not a diver, he just got a scuba diving trip. So we have 2 answers, we're gonna think about both of them. We have 2 questions, 2 answers here. So recurrence ipsilateral pneumothorax, failure for expansion. So the B is definitely right. C, so I think the only wrong thing in C is failure of expansion 5 days after chest drain insertions. So 48 hours is not correct. So the right answer here is P. The second question is about 45 years old female patient presented with unilateral leg swelling. She takes oral contraceptive pills. Which one of the following is not recognized as a major risk factor for DVT? So he's asking here about major risk factor. So the only major risk factor, so all of them might be a risk factor, but some of them will be minors, and only one of them will be major risk factor, which is correct. Previous history of DVT is a major risk factor for DVT. The third question here is a 25 years old male brought by ambulance after experiencing generalized body rash and facial swelling following a spicy meal in a restaurant. He had an injection of a medication by crew. He looks well. Now he lives nearby with his parents. He has 2 doses of up-to-date EpiPen. He knows how to use them. How many hours of observation will this patient need? So the question here about the observation time after anaphylaxis. So we have 3 times, 2 hours, 6 hours, 12 hours. So we don't have 4 hours, we don't have no observation. So we have 3 options here, 2, 6, 12. If the patient has only one single dose of adrenaline and the patient looks well, doesn't have any biphasic reaction, he lives nearby, no chronic illnesses, so and he had a EpiPen and learned how to use them, so we only need 2 hours. This is the answer in our scenario, which is answer C. We will have another question similar to that one. I will show you the difference and how can we answer them. The fourth question here, and about a patient, elderly, with a history of polymyalgia rheumatica, coming to the ED complaining of jaw ache on mastication, temporal headache, and malaise. His ESR is 97, he is abirexical, his visual acuity is currently 6/9 bilaterally. From the history, you can understand that this patient coming with possibly GCA or temporal arthritis. So the treatment for temporal arthritis is a steroid, whether oral or IV. So here we have an answer about antibiotic, so we will discard this answer, which is answer A. So we have 4 answers containing steroid. So we have prednisolone, methylprednisolone IV, or oral prednisolone 1 milligram, or we have hydrocortisone. And also answer D will be discarded because it's speaking about analgesia and just doing a temporal artery biopsy. But this patient will need a treatment. So if the patient doesn't show any ophthalmology problem, so the patient will take an oral steroid. So the only option here is option C, which is immediate oral prednisolone, 1 milligram per kg per day. If the patient show any eye problem like loss of vision or anything, he will need an immediate IV methylprednisolone, and this will be the answer B. But in our scenario here, the answer will be C. Correct answer. Another question here. 3-month-old child has been probed by his parent after experiencing an episode of being floppy for 40 seconds with no obvious seizure. Parents started CPR on him and he came back to his normal. He is full-term delivery and he has previous similar episode before. Which factor mandates admission for faster review and evaluation? So first we need to know what is this patient's. So this patient is Brew. So the patient is coming with Brew. It is high risk or normal risk. So he's not asking about this one, the management, but he is asking about what is a high risk feature in this patient. So his age, so 3 months is not a high risk. Duration of event is 40 seconds, less than a minute, so it's not a high risk. Being floppy, this is a normal or a definition of really CPR by parent and previous episodes. So we got two answers. CPR, yes, it's a major, but CPR done by trained person. So if he said that CPR by the ambulance crew, this is considered as a major risk, but CPR by parents doesn't consider as a major risk factor as it's done by non-trained personnel. So we will take this answer away from the correct thing. So we got previous episode of Brewy, which is a high risk. So the answer here is E. So think there is a bit of only words can change the correct answer. Another pediatric question: a 30-month-old child has been probed by ambulance after having a fall at home. On initial assessment, he noted swelling in his head about 6 centimeters, bruises in his chest, and possible femoral deformity. He vomited once and had 2 minutes episode of loss of consciousness. Which factor will make you request a CT head in this child? Think about everything. So he's asking about here the NICE guidelines for the pediatric CT after head injury. We got the age, 30 months, and we got the size of the bruise, 6 centimeters, and he vomited once, got possible femoral fracture, and 2 minutes loss of the consciousness. His age, yes, he's a child, but this is it's not like a criteria to ask for a CT head. Vomiting twice, no, this NICE guidelines say 3 or more vomiting. Head bruise, so yeah, we have a big bruise which is 6 centimeters, but it should be less than a year. This child is 13 months, so he is more than a year, so we are not depending on the size of the bruise in his age. Loss of consciousness, he lost his consciousness for about 2 minutes, but the NICE guidelines say 5 minutes or more. Presence of femoral fracture. Oh, why he bought this one? It's not related. But in his age, 13 months, long bone fracture, we consider an NAI, non-accidental injury. And the first criteria in the NICE guidelines say if you suspect non-accidental injury, you should request a CT head. So the indication for a CT head here is presence of femoral fracture for the non-accidental injury. So it's quite complicated, but it's a good question as well. So the answer here is E. The next question about 55-year-old male brought by ambulance after experiencing generalized body rash and facial swelling following a spicy meal in a restaurant. He had an injection of a medication by the crew, and he looks well now and he lives alone, known to have severe asthma, under control of a medication. He has 2 doses of up-to-date EpiPen and he knows how to use them. How many hours of observation will need this patient? So first we will take away no observation and 4 hours, as there is no it's not from the guidelines or observation time. So this patient is a stable patient, but we got here criteria for prolonged observation time, which is he has a history of severe asthma and he lives alone. So the answer will be correct, E, 12 hours. The next question about a concerned mother attended ED with her child. Following her 6-week baby check, she noted that the GP mentioned a heart murmur. The child is well with normal examination. There's a continuous systolic murmur. What is the most likely lesion or the cardiac abnormalities? Through the stable, prolonged murmur, you will find the N, VSD, which is option C. The next question in the examples here, we have a question about abnormal finding in the CT scan, which is called accidental finding, and what are you gonna do for this patient. So you are night shift, shop floor lead. The patient came with abdominal pain and CT scan reported as there's 8 centimeter suprarenal mass for fatal CTQP, and what you should do for this patient. So this is one of the managerial question, and the GMC recommend that if you find anything critical, don't do it like make someone else do the scan, but do it yourself and inform the patient. So the correct answer would be D. The next question will be about 45 years old male patient, had a sudden onset headache, right side neck pain, no vomiting, no blurring of vision, previous neck injury in a bike accident, and he asked about definitive investigation to diagnose this patient. Is not the next investigation to be done, it is about the definitive investigation. So read the options and choose one. Correct. So the correct answer here will be D, MRA, head and neck. If you're asking about the next investigation to be done, will be CT head and neck with contrast. So the next question about a man, 26 years old, had a street drugs coming with torticollis, trismus, upward gaze. 2 doses of the first line treatment have failed to resolve his symptom. So this symptom with the torticollis and trismus most likely would be dystonic reaction caused by antipsychotic medication. The first line will be procyclidine, but he is asking about the second choice. So the answer will be correct, D, IV diazepam 10 mg. So the next question about straightforward one, which is asking about ECG finding. So the patient here showed prolonged prolongation, so you can easily diagnose Moffitt's type 1 AV block. This question is about dental emergency. So take your time to read the scenario and think about the answer, and we will do it together. So a patient, 48 years old, He's not registered with dentist. His presentation is sore mouth for the past 2 weeks. Low grade temperature 37.7. He got erythema and swelling of the gingiva with gray membrane covering the upper part of the gum. So this is a compound question. He is asking first about the treatment, but you should know the diagnosis. So the diagnosis here is trunch mouth or gingivitis, and the treatment is correct is answer A. 3-day course of either amoxicillin or metronidazole is appropriate for his problem. And FY2 doctor asking you to review 80 years old male patient presented with mechanical fall. Then he asked you about the clinical frailty score, which is very common question in the exam. So it's very hard to recall each grade, but try to get the landmark for each grade in the clinical frailty score. So what is the landmark here, or what is the spot diagnosis for his grade? So the patient is here, slowed up. So when you see slowed up, that means that he is vulnerable or grade 4. So the answer here is B. Another child, 4 years old, brought by ambulance to resus room with active seizure about 7 minutes ago. You are the doctor who covering the pediatric emergency. First dose of buccal midazolam has been given. The child is still seizing. What is the best next step to do? So the patient starting seizing 7 minutes ago, and already he has 1 dose of buccal midazolam. So give another dose of diazepam as soon as possible. Wait till pediatric registrar to come and assess the patient. Move the patient quickly to CT scan. Wait 5 minutes for second dose of benzodiazepine, or obtain IV line and give levetiracetam, which is Keppra. So according to the algorithm in fitting child, so the first line will be benzodiazepine. If we got a line, will be lorazepam. Wait for another 5 minutes to give a second dose of benzodiazepine. If we got a line, we can give a lorazepam. If there's no line, we will give the buccal midazolam or rectal diazepam. So the patient has already the first dose, so the second dose should be given after 5 minutes to give the benzodiazepine, which is the correct answer is D. 28 years old patient has been seen by FY2 doctor after experiencing 3-day history of fever, neck pain, and non-plunging rash. The FY2 doctor asked you about the normal pressure of the CSF. What will be your answer? So this is also a straightforward question. It's not a scenario. It's testing your knowledge about the CSF. So the normal CSF in the patient is 7 to 15, or some books write it as from 8 to 18. So 7 to 15 or 8 to 18 would be the normal range for the CSF pressure. 17 weeks pregnant female came to the emergency department with vaginal bleeding after a significant fall at home. He is asking about the amount of anti-D you should give to a rhesus negative lady after a trauma. So before 12 weeks, you will give 250 if a major bleeding. From 12 to 19 weeks, you will give 250 as well. Above 20 weeks, you will give 500 international unit and consider cohort test. So the answer here is 250 and don't do cohort test. The next question about traumatic cardiac arrest. 30 years old male patients coming in a trauma call. He witnessed a cardiac arrest. There is no cardiac activity noted. The ambulance crew told you that he was breathing earlier. What is the next step to be done? This is a traumatic cardiac arrest pathway. So the first line of treatment will be do bilateral thoracostomies and stop major bleeding. So it's different from the normal ALS. If it's an ALS protocol, so we will do CPR and give adrenaline. But in the traumatic cardiac arrest, we stop the major bleeding by doing bilateral thoracotomies, pelvic binder, activate major hemorrhage protocol. This is the first priority in the traumatic cardiac arrest patients. So the next question asking about your knowledge of the neonatal resuscitation. So what is the accepted preductal oxygen saturation for a neonate when you measure after 2 minutes? So definitely 2 minutes will be 65, 5 minutes will be 85, and after 10 minutes will be 90. So the answer here is correct, is B, more than 64. The last question in our presentation is asking about 26 years old female has been probed by ambulance with sudden onset of collapse. On initial assessment, her respiratory rate was 8, oxygen saturation was 89% on room air. You suspect opioid overdose and gave her titrating dose of naloxone. Initially, the patient started to gain her consciousness and her respiratory rate became 13 and oxygen saturation raised to 95%. What is the best step to be done or the next step to be done? So the patient here is opioid overdose. According to the recent guidelines for the opioid overdose, if the patient doesn't take any naloxone and he was stable, respiratory rate more than 10 and saturation more than 92, so observation time will be 6 hours. If the patient came with low saturation or reduced respiratory rate, the patient in our scenario, and he received naloxone, he should be observed for, correct, he should be observed for 4 hours. So the right answer here is monitor for 4 hours after naloxone and send her home if normal. So we reached the end of our presentation today. I'll give you a link for our Telegram group to join us for our FRCEM SBA course. You will find lots of guidelines, lots of questions, mock exams, and you will find support all the time and even before and after the exam as well. Hopefully this short presentation give you a bit of help when you start to study for the exam.